So some background. In Maryland and across the country, investment in health data infrastructure, along with support for value-based payment demonstrations and innovation models, has laid significant groundwork for a robust foundation that supports clinical data exchange. And this was particularly evident during the COVID-19 pandemic, where HIEs were proven to be ready and invaluable assets for quickly deploying tool sets and sharing data streams that were used by state public health departments as well as healthcare leaders. So many HIEs, including Chris, demonstrated that they could serve as flexible partners that could be adopted and scaled to improve disease surveillance and shared reporting, as well as care team engagement. The national subject matter experts, including Civitas Networks for Health, developed a new definition for these organizations that have this enhanced functionality and meet broader stakeholder needs, labeling them Health Data Utilities, or HDU. HDUs are statewide models or entities with advanced technical capabilities to combine, enhance, and exchange electronic health data across care and service settings for treatment, care coordination, quality improvement, as well as public and community health purposes. So HDUs enable specific defined use cases with privacy and security that exceed federal minimum standards established with HIPAA to ensure patient privacy and appropriate data use. So HDUs leverage existing infrastructure by collaborating with state or regional HIEs. They often receive designated state authority and can serve as a designated data source. I just want to stress HDUs are not simply HIEs 2.0, and HDUs also will vary across state or regions, and they'll look different, especially as they evolve and implement, the implementation progresses of different HDUs. So let's talk a little bit about the value in HDU on the next slide. So some core features and potential use cases associated with HDU planning and implementation are laid out on the screen. I'm going to review some of them. So an HDU importantly combines structured data from multiple sources, such as payers, providers, consumers, community support services, government agencies, and even public health agencies to create scalable data repositories. HDUs can utilize investments in HIE master patient indexes to facilitate that data matching. And the advanced data sharing for the aggregation and integration of multiple data sets can expand analytics and quality reporting, data visualizations, and other services beyond the traditional clinical data exchange that's facilitated by HIEs. HDUs support not only clinical care delivery, but population health management and community health initiatives. HDUs can expand public health reporting to state and other geographic regions. For example, an HDU can facilitate data sharing of lab test results for reportable conditions to local public health authorities. HDUs can also offer enriching socio-demographic data that can be reported to public health agencies, allowing those agencies to assess and evaluate public health initiatives using that demographic data. So for example, capturing vaccine administration by race, ethnicity, location, or language based on matched patient data that could be found from hospitals or primary care programs or providers. HDUs can also enable comprehensive event alerts that include broadened and customizable information and clinical notifications. And HDUs can also advance value-based payment models to promote transformation in care. So this could look like comparative performance measures to guide quality initiatives. These are just a few examples of the value that HDUs can bring. And another aspect of an HDU that sets it apart from an HIE is the expansive multi-stakeholder cross-sector governance structure that includes both state and community partners. So the multi-stakeholder model allows the HDU to prioritize services and use cases through shared governance, ensuring responsiveness to and collaboration among all partners, including those community health initiatives. So in the next slide, I'm going to share a little bit more about how different stakeholders benefit from the HDU model. As everyone on this summit today probably knows very well, healthcare, public health, and community health data are often siloed. They're managed by different entities. They have different data sharing policies, and all of this can create challenges in combining data to further shared interest and goals. Restricted access and use of critical data limits the value of health information exchange platforms and can erode confidence in data completeness. So there's a growing need to effectively share and integrate data from multiple sources for many reasons, but especially as the healthcare ecosystem continues to shift towards value-based care. HCUs can serve the needs of many stakeholders by offering standardized data capture and interoperability across sectors, as well as analysis through robust technical infrastructure. So this slide depicts a few stakeholders who could benefit from the HCU model. I'm going to review some examples of how they may benefit. So for our state health IT governance, HCUs can enable statewide data exchange services across geography, sectors, and settings to support administration health priorities and multiple agency data needs for data-informed policy, data-informed programs, and interventions. For Medicaid, HCUs can support Medicaid agency waivers and programs that support whole person care, enhanced care management, and community services for vulnerable populations. For our public health folks, HCUs can facilitate access to real-time comprehensive data sets that inform planning, resource allocation, preparedness, and response. And for our providers, HCUs can reduce provider burden by reducing duplicative reporting for public health, quality measures, or other compliance requirements. HCUs can also facilitate the integration of data into clinical workflows. And then for our community partners, HCUs can support standardized data capture and cross-organization data exchange to facilitate integrated data for population health analytics. And these are just some examples of how varied stakeholders could benefit from HCU's capacity for facilitated data sharing. I just want to stress HCUs are envisioned to support not just providers, but consumers and the public health, while also facilitating multi-stakeholder collaboration. So I've talked a bit about HCUs broadly. On the next slide, I'm going to talk a little bit about what's happening in Maryland. Thanks, Kevin. So Maryland law enacted in 2022 establishes an HCU, and this is the first state law designating an HCU. The law requires an HCU to collect, aggregate, and analyze clinical information, public health data, and health administrative data to assist state agencies and local health departments in evaluating public health interventions and supporting health equity. So as a state HCU, CRIS will facilitate the communication of data between public health officials and healthcare providers to advance disease control and support care delivery. And the law also requires CRIS to collect dispensed information for non-controlled prescription drugs and make that data available for clinical and public health purposes. And in a few minutes, Laura is going to share a few more examples about how CRIS is functioning as the HCU in Maryland. But before we get there, on the next slide, I'm going to share a little bit about the development of the framework for implementing an HCU. So in 2021, MHCC convened meetings with state leaders and HIE representatives to discuss opportunities, challenges, and solutions to advancing information exchange. And these discussions highlighted the need for HIEs to function more broadly as a data utility to support providers, consumers, and all those we've been talking about so far. So following that initial meeting where it was discussed that there is a need for HIEs to move into this HCU model, MHCC partnered with Civitas Networks for Health and the Association for Health IT State Leaders to hold a roundtable series in 2022. And our participants in the roundtable included HIEs, state agencies, regional health improvement collaboratives, and other stakeholders involved in public-private health data partnerships. And the roundtable discussions centered on collaborations that support HCU implementation, HCU governance, the role of states in overseeing HCU operations and use cases, as well as HCU sustainability. So in the roundtable series, we heard from stakeholders that there's a need to develop a framework for not only defining, but implementing an HCU. After that roundtable series, MHCC partnered with Civitas to develop an HCU framework that will guide Maryland and HIUs nationally in the implementation of robust technical capabilities required to address health data access challenges in ways that achieve greater economies of scale and data liquidity to support care delivery and public health. So in the development of the framework, Civitas sought input from national stakeholders and subject matter experts by convening a national advisory council. And with these council meetings, they were held in the fall of 2022, and the council discussed the evolving HIE landscape and defined core components of an HDU, which was critical for the HDU framework. On the next slide, you'll see we, as a result of the partnership with Civitas and the Advisory Council and our stakeholders, MHCC has jointly released 2 helpful resources on HDUs. So on the left, in January 2023, the issue brief advancing implementation of health data utility models was released. And this issue brief outlines the history, the current state, and drivers for the emergence and advancement of health data utilities. And on the right, you'll see in March of this year, the Health Data Utility Framework, a guide to implementation, was released. And the framework provides guidance on the structure and implementation of HDU models to support multi-stakeholder needs across care and service settings by functioning as a health data resource for treatment, care coordination, quality improvement, community and public health purposes. Now, both of these resources are available as PDFs on the MHCC website, and there's also an interactive version of the framework on the Civitas website. And I encourage anyone who's interested in learning more about HDUs to visit and review both of those resources. On the next slide, I'm going to share a little bit more about some information found in the framework. I'm not going to go over everything in the framework, but when talking with all of these stakeholders, we identified several potential challenges or considerations for HDUs when assessing and planning and implementing or creating a sustainable HDU model. So a full description of the considerations, as mentioned, are in the framework, but I'm going to highlight a few themes that we identified when talking with stakeholders. The first one is implementing an HDU is incredibly resource intensive, as I'm sure you can imagine as I'm describing an HDU. And stakeholders may be hesitant to support expanded data sharing due to uncertain value proposition or privacy and security concerns and how the data will be managed and analyzed. HDUs must understand the market forces in their area. So key to understanding this is getting a firm understanding of the needs, the capacity, and the willingness of communities to participate in an HDU. And then key to that is an HDU being able to effectively communicate the benefit for them participating. So with that, clear and meaningful use cases need to be identified to showcase the value proposition of an HDU. And these use cases really need to come with community perspectives. So along those lines, it's incredibly important to obtain and maintain trust across stakeholders. And this creates a foundation for collective action and sustainability, as well as HDUs to become flexible models that can scale for future use cases. So again, there's several considerations that are important in developing this multi-stakeholder governance structure and implementing these robust use cases for HDUs. There's still a lot of room to grow and learn in this area. But on the next slide, I provide some contact information if you have more questions to direct me. We'll have time for Q&A after this. But I highly recommend reading through the issue brief and the framework. And then next up, we're going to hear from Laura on some use cases that CRISP is implementing. So Laura, I'm going to hand it over to you.
Great, thanks, Anna. And that was a really fabulous sort of underpinning and foundation for what we've been building on. So I'm going to be talking about things that, again, you've heard Anna talk about, you heard the secretary talk about this morning, if you're in this morning's session, on really how we are being a public health data utility. And one important thing that I like to think about is some of the core functions that we think of CRISP as serving are actually HDU functions. We were just doing it before there was a term for it. So if some of the things you're like, oh, I don't understand how that's different, it's because it is just a really unique and special function that we've already been performing in Maryland, that not necessarily in other places. So just to keep that in mind. Next slide, please. So here are some other pieces. When we sort of get that legislation in on being a health data utility, we took it back to a public health subcommittee and kind of thought about what that meant in principles. And so we did come up with some additional sort of principles we wanted to think about when we were thinking about a health data utility. And some of those things include health equity, a holistic whole person view, potential benefits and risks for communities and individuals, supporting public health interventions, promoting the health of all, and accelerating interoperability. Next slide. You may have seen this slide before. So here are some of the technical functions of a health data utility. And so what I really want to emphasize here, and I think Anna did a great job of emphasizing this, is this goes beyond sort of transferring data from one place to another, which is sort of the main thrust of HIEs, was really to make sure that data could be where it was needed to be for treatment purposes. The idea of an HDU is really that there's additional value being served. It's not just moving data from one place to another, but really having all that data in one place in a thoughtful, well-governed way can make data better and give us better insights. It gives it much more valuable for the end users, and the user experience is enhanced as well. Next slide, please. So some of the things that we are doing at CRISP, and I'll give you some specific examples in just a second, but we are leveraging data feeds for multiple use cases. We're doing things like looking at hospital HL7 feeds and seeing if we can use them for public health dashboards. We did that during COVID. Understanding that certain data that previously wasn't at the point of care, like Medicaid claims, can be shared at the point of care. Having an opportunity for collaborative governing bodies to actually share ideas and recommendations so people can understand what data is being used and how and why. I think the why there is really, really important. And then launching pilots by leveraging existing infrastructures and staff, and really being able to base it off of real world results. This is not, just sort of a concept or a term. We're actually implementing some of these things and seeing what works and doesn't work as we sort of step into this space and continue being in this space. Next slide. So now I'm going to get into the promised examples. I picked a couple here. There are a lot. There are many, many examples. We just wanted to pick a couple that were sort of top of mind and really interesting for folks. So as a lot of people know, with the end of the public health emergency, folks are being asked to be redetermined for Medicaid eligibility. Over the course of 12 months, Maryland Medicaid is going to have a renewal of every participant enrolled in the state's programs. This could be problematic in some ways because patients may be showing up to appointments without coverage. If they find out that they don't have coverage, they may need to reschedule their appointments and delay necessary care. And Medicaid folks might not have the right contact information for those patients. It's been a couple of years since they had to update that information, and people may have moved. And so in partnership with Maryland Medicaid, CRISP is providing interested providers with a monthly list of their patients who are up for redetermination in the next 90 days. So this is sort of a choice that people can opt into to get that list so they can do outreach and really help to ameliorate any negative impacts from not knowing about redetermination or things like that, really just sort of connecting the dots between our health systems in a way that wouldn't necessarily be there without the HDU. Next slide. Another really exciting one that we've been able to do because of our partnership with MDH and Immunet through COVID is we've really expanded our ability to access immunization data. And so in this use case, schools require their students and families to provide proof of required vaccinations. And families will either submit documentation or the school staff accesses Immunet one by one. This can be a significant burden on both staff and families and doesn't allow them to focus on the folks who actually, might be having trouble getting vaccinations or don't know what the rules are. So because of our partnerships during COVID, we can actually provide linked lists of students and their vaccinations. In this use case, Baltimore City Public Schools provide student rosters to CRISP and conforming to all of the education regulations, in this case it's called FERPA. We are able to match this to Immunet to generate a list for them. And we worked very collaboratively to enhance the matching algorithm to make sure that we used our master patient index, but we also sort of understood the exact context and frameworks of different populations that might have slightly different needs. And this was actually really, really effective. It significantly reduced staff time from, 10 or so FTEs down to only a few for a few hours, and really being able to reach out to just those populations that really needed the support. And we are expanding this to other districts. So if you are in a school district and you're interested in something like this, we're definitely open to expanding it. We're expanding similar types of outreach. But again, this is not something we could have done previously. This is really about bringing that public health data to the community and where it needs to be in an effective way. And we now have the technology to be able to support that. Next slide. And I'll go really quickly on this one, and folks may have heard about this one. There are statewide goals around a lot of population health needs, and one of them is asthma and maternal and child health. And so the local health departments actually have dedicated home visiting programs to support environmental modifications for kids with asthma. But they've been having trouble enrolling people because they don't necessarily know who is really at most at risk. So we are able to send referrals to local health departments for Medicaid beneficiaries who are recently in the hospital, which led to an increased referral acceptance by families. So again, this is really about combining data and bringing it where it needs to be so that people have access to programs and systems that they didn't previously have access to. So it's really about connecting the dots between the community and public health. Next slide. And as Anna mentioned, and something that you'll probably sort of start thinking about as you look at these use cases, these are not typical. This is not necessarily what you would expect data to be flowing as. And so it's really, really important to think about data use and access. So sort of the bedrock of everything we do is HIPAA, is patient privacy, and making sure that we are only releasing data that is allowed. We have use cases for the participant data that is sent to us. We make sure it goes through clinical committees and things, and it is approved by people for use. And we also have data agreements. All of the data from MDH, from Medicaid, is all governed by those data agreements. And because of all of those data use and access, we do look at sort of the uses and the why differently. A clinician seeing data for treatment is considered differently than a local health officer managing population health. They have different needs and they have different access levels, and we're able to manage those and make sure that we are keeping those throughout the system. Data use is increasingly complex. We can now do things that we never even thought of 3 years ago. We have lots of different agreements under this. We have the participation agreements, we have data use agreements, as I mentioned. Trying to make sure that we're sort of staying in line with everything is what gets challenging. There might be a really, really awesome idea about how to be an HTU, but if it's not appropriate to share that data, we're not going to do it. And so we end up having to balance those pieces a lot of the time. And that kind of gets to this bottom piece, which probably is like the most important thing, which is that we are a trusted third party. We only exist if patients and participants continue to want their data shared, and any patient can opt out at any time for any reason. So just understanding that while we have all of these amazing opportunities, we have to be really thoughtful about how we connect, share, and use data. So that it really is something that people are excited about and feel comfortable with and don't feel like their data is being shared unfairly. And I think that maybe my last slide, let's see if there's, actually there might be one more, thank you. So we have some challenge and opportunities. It is hard, as you heard me say, even all these different use cases, these different data agreements, there is a lot of coordination that required on these different feeds and pipelines. It is, a lot of work to make sure that we are securing our critical accesses and we are really providing that access all the time that doctors are using, ensuring consistency in reporting, making sure we have an equity lens, and collaborating across our affiliates across the region. So we have a lot of things coming up. We are working on a lot of exciting projects, and we are really thrilled to be working with the state and with MHCC to be the state HCU.